Hello, good afternoon, my dear professors, colleagues, students, and audiences. Today, I'm honored to start the second day of the joint program between Yeditepe University of Istanbul, Turkey, and Tehran University of Medical Sciences. As you all know, the main core of this program focuses on dental and emergencies which happen during the practice. So today, we are not exception. We will start the orthodontic panel with two of my great colleagues, Dr. Mohammed Ali Keshvat from Tehran University and Dr. Gonca Yildirim from Yeditepe University. And afterwards, we will have the pediatric panel followed by the endodontic one. So we will start with Dr. Mohammed Ali Keshvat, our young, talented colleague, who will talk about functional shift of the mandible, which has a simple preventive strategy, but gives a great service to the patients. So, Dr. Keshvat, are you ready?
Yes, I'm ready here.
So, thank you very much. Please start today.
Hello, everyone. This is Mohammed Ali Keshvat from Orthodontic Department of Tehran University of Medical Sciences. Today, I'm going to talk about functional shift of mandible, simple prevention, great therapies to the patients. Okay. First of all, I start with the place where I come. This is the Orthodontic Department of Tehran University of Medical Sciences, a very nice and intimate place with great colleagues, students, and residents who give you more and more energy every day and assure you that being a teacher is the best choice that you could ever have in your life. At the end of my presentation, I have two simple questions here that I expect you to be able to answer, which is about the lecture that I'm going to talk about, and stay focused and with a little concentration, I'm sure that you can get the point. The first question is about the premature contact in some teeth that can lead to functional shift of the mandible, and the second one is about the appliances that can have a role in eliminating functional shift and treatment of these patients. My main reference during this lecture is the 6th edition of Contemporary Orthodontics by Dr. William Profit, chapter 11, and also some of the clinical experiences I have learned from my beloved professors during these years. At the first step, what is the functional shift of mandible? It is the deviation of the mandible during closure from the first contact to the habitual occlusion. In the other words, deviation from the centric relation to the centric occlusion. It means that while the patient closes his or her mouth, he deviates his mandible to one side, and this leads to the midline discrepancies between two jaws, and also a facial asymmetry, which is called pseudofacial asymmetry. It is believed to be the main cause of pseudofacial asymmetry. So let's look at this video, which is made at our department. We have a patient here that in the first contact of the teeth, there's no problem. We see facial symmetry. And after that, going to the habitual occlusion, we see a shift to the left side of the face. Look at here, this is the first stop, midline is on, and now there's a midline discrepancy and facial asymmetry. This is called functional shift of the mandible. So there's some differences between true asymmetry and asymmetry due to the functional shift. At the first step, in the functional shift, we just see the asymmetry in centric occlusion. For example, when the patient is in centric relation, when she or he is speaking, talking, resting, smiling, there is no sign of deviation. But when going to the habitual occlusion or maximal occlusion, there is an asymmetry in the face. And also, we see a lateral mandibular movement during the closure of the jaws. But in the true asymmetry, there is asymmetry in all situations, while smiling, while in rest, while speaking, in CR, in CO, and there is no documents and no sign of lateral mandibular movement during closure. So keeping this in mind, which one of these patients may have a functional shift? Which one of these patients have a true facial asymmetry? Most of these patients are smiling. And as we know, during the smiling, most of us do not occlude our teeth together. So the boy on the right side who has asymmetry, when the teeth are not even in occlusion, is expected to have true facial asymmetry. While the girl on the left side is symmetric, while the teeth are not in occlusion, but we don't know, she may or may not have a functional shift when she closes his mouth and goes to the habitual occlusion. So we should see if there is a sign of lateral mandibular shift during the closure. What are the causes that lead to functional shift? The first culprit is a premature contact between some deciduous teeth, that is mainly canine and molars, primary molars, which means C and E. In this situation, the functional shift of a mandible for these patients is a way to escape from this occlusal interference, to have a more comfortable occlusion and to chew more efficiently. But the main culprit and the main factor for provoking a functional shift is a moderate bilateral maxillary constriction. In this situation, the patient has a bilateral posterior crossbite. In the CR, we don't see any deviation of the face in the CR, midlines are on, but after the closure, after going to the habitual occlusion, there is a shift to one side, either left or right. It means that in the CO, we have a deviation in the face, we have midline discrepancy, we have a pseudo unilateral crossbite on one side and a proper occlusion on the other side. This bilateral maxillary constriction serves as a dental interferences. And because of these dental interferences, the patient shifts his or her mandible to have a more comfortable occlusion. What happens during mandibular closure? This is the intraoral view of the girl that was smiling on the previous slide. She had bilateral maxillary constriction on both sides, but because of these dental interferences, when she went to the habitual occlusion, to the maximal occlusion, to the centric occlusion, we see a shift toward the left side, a mandibular shift, a facial asymmetry, and also a midline discrepancy. If we had a photograph of the extraoral view, we could see the deviation of the mandible and asymmetry in the face too. Here we have an important question. Does every maxillary constriction lead to functional shift? Definitely no. Greater maxillary constriction may allow the maxillary posterior teeth to fit inside the mandibular teeth. So in this situation, there is no deviation, there is no interferences, and the patient feels comfortable both in CR and CO. Look at the occlusion in the CR and CO. Both of them are identical. No deviation of mandibular shift, no deviation of midline shift, and everything is just the same. Another situation is unilateral maxillary constriction, true unilateral maxillary constriction. Again, in this situation, centric relation and septic occlusion are the same. There is no shift of the mandible. Midlines are the same in both situations. And its etiology is because of the unilateral collapse of the maxillary arch. So both in CR and CO, we see a true unilateral posterior crossbite. It has a different etiology and totally different treatment plan from what we are talking about today. What is the treatment of functional shift of mandible? Well, etiology comes first. Where there is a primary molar or canine tooth contact and premature contact and dental interferences, our treatment of choice are equilibration and occlusal adjustment. We should grind the teeth and eliminate these functional shift, which is because of the premature contact of these teeth. But if the problem is the maxillary constriction, we should use our orthodontic appliances to expand the maxillary arch. What is the protocol of maxillary expansion in these cases? The most important factor for choosing the best appliance are age and patient cooperation. We divide the patients into two main groups, early mixed dentition and late mixed dentition. Maxillary expansion in early mixed dentition is achieved with different orthodontic appliances. One of these appliances is WH. Its components are molar bands on first permanent molars and also 36 mm steel wire, which is connected to these molar bands on the palatal side by welding. WH can be activated by opening the apices of WH and is easily adjusted to provide more anterior than posterior or vice versa expansion. It is de-cemented every session by the orthodontist, opened 4 to 6 mm wider than the passive form and cemented again. So it has some clinical procedures and maybe time consuming. Another option is Spothelix. Spothelix is a more flexible form of WH. It has molar bands again on first permanent molars, 4 helices, 2 anterior, 2 posterior, and 38 mm steel wire, which is connected by welding to the palatal side of the molar bands. The 2 helices on the anterior side is bulky enough to serve as a reminder for patients who have finger sucking habit. The extra wire incorporated in this structure is gives a slightly greater range of activation than the WH plus, but the force level of these two appliances are the same. The clinical process is the same as the WH. And here is the most common appliance that we prescribe for our patients with the constriction of the maxilla in Tehran University of Medical Sciences. It is a removable appliances. It has a midline jack screw, Adams clasp or delta Adams clasp on molars and premolar teeth, which helps to have a good retention of the removable appliance. And also we may or we may not have a labial, which is optional. This appliance consists of a midline jack screw, as I said. This midline jack screw should be opened once or twice a week by the patient. Each turn provides a quarter of millimeter of expansion of the appliance. Also, good cooperation is a prerequisite for the appliance. And it is also the main disadvantage of this appliance. The patient has to wear the removable appliance as long as possible during the day and while sleeping. But in the late mixed dentition, what should we do? Due to the calcification and interdigitation of the mid-palatal suture, which begins in the late mixed dentition, our appliances of choice should provide heavier forces. Fixed jack screws, which is called higher axis screws, as we see in this picture, helps to provide more and more intense power, so there can be micro cracks in the mid-palatal suture, and we can have a good skeletal expansion rather than dental expansion in patients in late mixed dentition. Again, molars are banded. And in this situation, in this appliance and design, we want to have as more teeth as possible in the anchor unit. So if the premolars have erupted, we band premolar teeth too. Also, removable appliances and fixed appliances can have posterior bite plug. As we see here in the image, we have a posterior bite plug, but how does this work? How does this play a role in eliminating functional shift? Well, this bite plug unlocks the occlusion. By unlocking the occlusion, immediately aiding to resolution of a functional jaw shift. So the occlusion is unlocked, and it helps to have a resolution of functional jaw of the mandible into the crossroot. So we can add posterior bite plugs both to fixed appliances and removable appliances. So we are here talking about emergencies of orthodontics. What is the emergency side of this problem? Why it is urgent to treat these patients? Take a look at this patient, which referred to me in the university something around 3 months ago. A girl in her 20s, as we see, a great mandibular midline discrepancy between maxilla and mandible, and the premature contact that lasted a long time in the conning area. Look at the face. What was called a premature contact, what was called a pseudofacial asymmetry in the early mixed dentition, in the late mixed dentition, was not diagnosed at the right time, was not treated at the right time, and what we see today is a true facial asymmetry. The patient does not shift anymore, but she always have a symmetric face, while smiling, while talking in CR and CO, and her chief component was this deviation. This deviation was evident to her too. So what is the treatment plan in these cases? Expansion? No, this don't work anymore. We don't have any other option for this patient other than orthodontic surgery. We should use fixed orthodontic appliances, coordinating upper jaw, lower jaw, and use orthodontic services for these patients to have a symmetric face again. So I want to emphasize that a proper diagnosis in the right time is a great service to your patient. By simple appliances, removable appliances, fixed appliances, expanding the modularity arch, by grinding the occlusion, adjusting the occlusion, you can help your patient to escape from the orthodontic surgery. And I think this is worth to have a good knowledge, to use our appliances, and to have a good diagnosis and treatment plan to face this problem. In case of any questions, do not hesitate to send me an email to this address. And if there's any questions, I'm at your service.
Thank you very much, Dr. Keshval, for your great presentation. I found it interesting and informative. Now, please stay with us until we give the microphone to our great colleague, Dr. Gonca Yildirim from Yeditepe University. Hello, Dr. Yildirim. Hope you're doing well there. Dr. Yildirim's speech would be about handling emergencies, focusing on the broken wings and knowing wires. Well, Dr. Yildirim, we're waiting for your speech. Hello, good afternoon.
Hi.
Dr. Yildirim, good afternoon. We
Good
are
afternoon.
impatiently waiting to hear your invaluable speech. Good afternoon.
Okay, I'm sharing my screen right now.
Thank you.
Hi, everyone. It's nice to be here and share my knowledge for you in your clinic for your patients in those pandemic situations. Today, I'm going to talk about management emergencies in orthodontics. I'm a doctor from Yeditepe University Department of Orthodontics. First of all, we need to identify what is an emergency in orthodontics. For example, is it an intraoral disturbance that makes the patient feel bad, or if there is something swallowed by the patient. If there's a swallow device like expansion screw key or arch wire or a band, first of all, we need to be sure that the device or the stuff should be out of the respiratory system. After all, if it's out of the respiratory system, then it's going to come to the object to the type and the sharpness of the device. We should consider the shape of the device. Then we should always keep in mind that it's always a risk for general health. Afterwards, the patient should be followed with lung and abdominal radiographs for following like 2 or 3 days. And we should recommend the patient to consume like carbohydrate food, like pasta and potato. Wait a minute. And if it's an intraoral disturbance or pain, we should tell the patient that it's normal to feel pain after a clinical orthodontic session because we apply pressures to teeth. That's why it's so normal that the patient should, it's patient's pain or disturbance or stitchy stitchy of the gums. And it's always seen that with the patient's irritation of oral mucosa in the first 2 or 3 months, because they're going to get used to the volume of the braces. And it's always seen that the pressure side of the hand or sleeping habits cause irritation of oral mucosa. And mouth sores can be seen due to the loose brackets. And if the patient consumes like sticky and hard food, we can see split of a wire ligatures that we tie the arch wire to the braces. And until the patient gets used to live with the braces, we see rubbing irritations of the braces. And the most common thing is the elongation of the arch wire at the beginning of the treatment, because the wires that we use at the beginning of the treatment are thin and the wires slide so easily and it can come out from the distal side of the tube. That's why we call it poking wires, and it disturbs the patient's retromolar area. As we see, according to the sleeping side or hand position, you apply pressure to your cheek and intraoral areas with the braces. And as you see, these are the aphthous tissues and the rubbing areas of the braces according to the pressure sides. What can we do immediately? We can, how can we solve those situations? Easy and immediate managements. You can tell your patients that orthodontic wax is used. Painkillers are the main helpers for the pain. And at the pandemic situations, the patients couldn't come to our clinic. That's why I always recommend tweezer for the poking wires, and I'm going to show how. And topical medications for aphthous areas like Genji gel or Aftadur gels for those topical pain. For poking wires and at pandemic situations and at emergencies, tweezer should be held like this, as you see, and the wire should be bent like a curve and to be placed into the tube like this area. But in the clinic, you can use like Portuguese stuff to hold the wire, and you can put it into the tube. And if the patient cannot do it like this, the patient can use like wax on the distal side of the tube, or if the orthodontic wax is lost, I recommend my patients to use sugar-free hard gums. And they can be melted like it can be softer with the temperature of the body, and they can be placed as orthodontic waxes to the distal of the wire. Also at home, if the patient cannot do both, I recommend my patients to use nail clippers to cut the wire from the end of the poking side. What can we do in the clinic when the patient comes with a loose braces? First of all, we should remove the residual stuff on the enamel side. Then we should use etching like 15 seconds. Because it should not be more, because we are not trying to do a composite restoration. We are just trying to rebond the braces. That's why 15 seconds should be enough. Afterwards, you should not have of course the Transbond XT to put the braces to its place. You can use a flowable composite or posterior composite just to stabilize the braces, because the patient should anyway see his or her orthodontist to rebond the braces again. You just need to just stop the sliding of the braces and rubbing the soft tissues. And I created a little video to show you how what can be done at home at those pandemic situations if the patient cannot come to your clinic. This is a nail clipper, and the wire is like out of the braces and tubes and bended. Those situations hurts the cheek most. That's why the most important thing is to take it away. That's why nail clipper is the best choice to cut the wire. And afterwards, orthodontic wax should be used for the distal side of the braces. And the other one is split of the ligature wires. You can use the rubber of a pencil or a toothpick to place it. You just curl it and place it under the arch wire. And if it's not working again, of course, you can use orthodontic waxes on those braces. It's just to stop the irritation of the soft tissues, that's all. And we do some kind of 2x4 or 2x2 mechanics in mixed dentition patients. And those mechanics have long arch wires, and those arch wires are free. And if the patient consume hard foods that we do not recommend, the arch wire pokes out something like this. And if the wire cannot be put into the band or the tube, you should cut the wire from the anterior side and distal ends. But those parts are too close to moving areas of the lips, like canine areas. That's why it hurts the inside of the lips. When the situation is like this, you should use flowable composites to overcome the wire and to relieve that area. If you cannot cut the wire, you can use those burrs with green strip ones. You can cut the wire with the burrs. If the band is loose, for example, you can take it out with a plier in your clinic, or you can cut the band and remove the other parts. And if there's a wire coming through the band, you should cut it also, not to irritate the other soft tissues. And you should put, again, flowable composite to the distal sides of the wires. And sometimes we apply some appliances like irritating and like changing the oral positions of the wires and the teeth. And I say it's okay not to be okay sometimes. For example, we use Nance and it make a pressure to the palatal side ruga area, and when we take it out, we see something like a hyperemic areas like this, and it's okay. It's because it's going to be healed. It's going to be better. For example, TPA, transpalatal arches. When the patient swallows something and the patient feels pain on his or her tongue because of the pressure of the TPA, but it's normal. We should tell the patient that that is normal and it's going to pass. For example, the third picture is an expansion case. We should warn the patient if there is a big space between your anterior teeth, don't be afraid because it's normal. We just separate the maxillary bones from each other, and it's normal to see a space. It's the thing that we want. Another stuff about removable appliances, I put this picture especially, it's so good. That means if an appliance works as well as we need, it's gonna start to hurt the palatal side or the soft tissue parts of the oral mucosa, because the appliances shape changes and the soft tissue changes when we expand. That's why we should trim from specific areas when we do expansion. Something like, for example, a palatal side of the maxilla and the back of the incisal teeth. And in the lower arch, we should trim from the lingual part of the anterior area, and you may see of those irritations, especially in retromolar areas in lingual site. You should check all those areas if the patient has an irritation. And if we see a breakage of the appliance, the patient should not do anything. They may try to use glues to fix the appliance, but they should not. Just stop using the appliance. If the appliance is broken, then go to your orthodontist, we should say. And if we see an instability of a removable appliance, you should not have, and of course, our pliers. We are using different kinds of pliers. If there is a plier you can use to squeeze the anterior side like this picture, or you can, this is an Adam's clamps. We can bend something, bend the U part of it like 30 degrees to stabilize the Hawley appliance. We can see face bulb irritations to lips, and the patient of yours may call you if the patient cannot reach his or orthodontist. You should hold the posterior side intraorally, then just turn the outer bow downward, not to irritate the, and we can, and there's also face mask irritation, because face mask takes anchorage from cheek, from the chin. It puts pressure to the chin side, and the patient tell you that there's a scar on the chin. We can recommend the patients that cotton to be used to stop the pain and the pressure. And lastly, we can have clear aligner emergencies. Nowadays, it's so popular for our orthodontic treatment options. Aligners may be lost. Aligners may cause gingival irritations. What can we do if the aligner is lost? We can take an impression just for those days, prevention of the relapse. Or we can shorten the vertical length of the aligner with cutting it or sandpaper usage. And the another emergency about the aligners, the patient may have pain with the muscles. Those are generally our bruxist patients. What can we tell them? You can use painkillers or muscle relaxants, or you can be happier in your life not to squeeze your teeth. And that's the end of my presentation. My last slide is gone. I'm sorry.
So thank you very much, Dr. Yildirim. Thank you very much for your great presentation.
Thank you.
I'm pretty sure it would be very, very useful for our students. Now we will start the discussion panel regarding the orthodontic panel. I would like to start with Dr. Yildirim. So, Dr. Yildirim, if you want to have a conclusion and suggest a set of tools or appliances to a general dentist to have them so they can use it in case of any orthodontic emergencies and handle that emergency until the patient can have the access to his or her orthodontist. Okay, what set of tools do you suggest them to buy?
A kind of pliers that we use, for example, I showed in my presentation. Prosthodontics pliers are always helpful for us. Anyway, I cannot say that plier or that tool, because the every tool in a clinic, for example, irotators and burrs can do the cutting stuff anyway. Just prosthodontic plier can be used to squeeze or bend. For example, that's why I cannot recommend any orthodontic orthodontic stuff to be bought in a clinic, because they are all special. They have special duties to be done. That's why prosthodontic pliers or irotators and burrs can be helpful anyway.
Yeah, thank you very much. I would like to ask our honorable participants if they have any questions. Now is the time for raising your hand, so we will be able to answer your questions. You can just click on the hand or the microphone beside your name, and we will see that your hand is raised in the Zoom, and we can activate your microphone. So I'll be waiting for dear participants to ask their questions. Now, right away, I can't see any questions. So I will continue with Dr. Keshwat. So Dr. Keshwat, thank you very much for your presentation. You talked very comprehensively about, the functional lateral shift. But you know that we also have a functional anterior shift of the mandible. Is there anything you want to share with us about the anterior functional shift?
Yes, thank you, Dr. Abt. It's a really important question. We have another functional shift in another dimension, sagittal functional shift, which makes the patient to have a reverse jet. In these situations, we should ask the patient about the genetic basis of mandibular prognatism or maxillary deficiency in the family. We should also look at the cephalometric analysis of the patients at the indexes like width appraisal, SNA, SND, or AMB, and the position of the maxilla and mandible to rule out the skeletal problems. And also, we should check the patient if she or he can whether have a edge-to-edge relation in the anterior teeth. If there is no sign or evidence of mandibular prognatism in the family, if the cephalometric analysis are in the normal range, and if the patient can have an edge-to-edge relation, we can use orthodontic appliances, for example, removable appliances, finger springs behind the upper lateral and central teeth, or activation of labial bone in the anterior region of the mandible to eliminate this shift and to help the patient to have a proper occlusion. By neglecting this kind of functional shift, also we may develop a class 3 skeletal problem, and we may have a mandibular prognatism in the upcoming years. And also the treatment of this kind of shift is also an emergency in orthodontics.
So thank you very much for your explanations. I still can't see any raised hands, so we go back to Istanbul. Dr. Yildirim, you mentioned that in case of some types of irritations, patients can use orthodontic waxes. So in case the patient doesn't have orthodontic wax and doesn't have access to the orthodontist, is there anything that they can replace, anything more accessible that can help relieve the patient's pain and irritation until she can visit her orthodontist?
I told in my presentation that if the patient does not have an orthodontic wax, I recommend them to use sugar-free hard bubble gums.
Yeah, thank you very much. So it can prevent the irritation until the patient can have access to.
Yeah, sugar-free gums are the best options because they're hard. And they can be they can get soft with the temperature of the body, and they can shape it and put it as an orthodontic wax.
Thank you. And do you recommend the general dentist to rebond the debonded bracket in the proper position, or no, you prefer that they remove the brackets?
Sometimes the arch wire is too thick. That's why they cannot remove the bracket. When they do, they break the other bracket also. Yeah. That's why I recommend.
It happens frequently.
If the loose one is the tube, for example, in the distal side, they can remove the tube and cut the wire from the distal part. But if the bracket is in the middle, for example, anterior teeth or premolars, if the dentist cannot remove the bracket, they can just put a flowable composite to stabilize it. They just remove the residual bonding stuff and put etch like 15 seconds, then flowable composite just to stabilize. Patients should truly tell the orthodontist that the bracket is loose, and I went to my dentist and he or she just put a flowable composite just to stabilize, because the moving bracket always rubs the soft tissue when we eat or something like this.
Yeah, thank you. So it seems that one person has a question, but I can't see the raised hand. This is a message from my dear colleague, Dr. Didem. Since I can't see the raised hand, Dr. Didem, you also can activate their microphone.
I think they're not able to speak right now, Dr. Arab. So it was Dr. Sales, he or she, I don't know, told that we're not able to talk right now. So they were asking about using the nail clippers, I think. So they were asking I think, Dr. Yildirim about, isn't it dangerous to cut the wire? I'm just reading the question. So the question says that, is it dangerous to cut the wire with nail clippers? Won't some fragments of it cut off and cause injuries and bleeding? That was the question.
It's an emergency management anyway. That's what I'm talking about. Of course, if you can take your child or the patient to the orthodontist or a clinic, the dentist or the orthodontist can solve that problem. It's a pandemic situation. That's why the patients may have general health risks and cannot leave the house, for example, or can be a COVID patient, for example, and can go out. If the situation is something like this and the patient get hurt by the wire, we should do something at home. We should solve that situation. It's anyway hurting. The danger is not the breaking another bracket. The emergency stuff is the pain, because when soft tissue is get hurt by the poking wire, the patient cannot eat, it bleeds. That's why it's not dangerous to cut the wire. When a parent has a clipper, they can hold the cheek away and place the clipper accordingly to the wire and cut the wire. There's no danger to that if they hold it and not chew the wire or make the children swallow the wire. If the stuff is held properly, there's no danger to do that.
Yeah, thank you very much. And I want just to add this because this is very important. This is important for the parent to keep the terminal part of the wire in the hand under control. Otherwise, it will just jump into the patient's maybe airway and make another emergency situation. So they should be quite careful that this situation doesn't happen. Thank you very much, Dr. Keshwat. We come back here to Tehran. As I saw in your slides, one of the fixed expander appliances had the posterior bite block, but your remover appliance didn't include it, if I remember correctly. So was there any special reason for that?
No. As I mentioned in my lecture, we can ask the laboratory to add posterior bite plugs to removable appliances too. The posterior bite plug is not just for fixed appliances; it can be added to removable appliances too. And one point that I forgot to talk about is the rate and the speed of opening the screw of fixed appliances, of Pyrex appliances. There are two protocols. Some says a slow expansion, some says rapid expansion. In a slow expansion, we ask the patient to open the screw once every other day, and in a rapid expansion, we ask the patient to open the screw twice a day. But the research has shown that there is no clinical differences, significant clinical differences between these two protocols. But in terms of soft tissue irritation and simplicity, we ask the patient to use the slow protocols.
Okay, thank you. And specifically for people who are newly graduates and don't have enough experience, it is not easy for them to distinguish between a real asymmetry and a functional shift. Is there anything you can recommend them?
Well, the most important thing is to check the patient in both situations, in CR and CO. When we ask the patient to close his or her mouth, to have the maximal occlusion, to have the habitual occlusion, and then we decide about the problem, about the malocclusion, we might be misguided. We might be misled by the face of the patient, by the asymmetry. We must distinguish between these two situations. We have to ask the patient to first slowly closes his mouth, closes her mouth, and to be able to distinguish any shifts, and also we should pay attention to the midline discrepancies. If we have a unilateral posterior crossbite and evidence midline discrepancies between these the two jaws, we should be hesitated about the presence of a functional shift.
Yeah, thank you. And I also suggest that in case that a patient has a unilateral crossbite and the dentist is not sure that if it is a functional shift or it is not, there is always a way of referring the patient to an orthodontist, or just ask help from a more experienced colleague just to have a correct diagnosis. Thank you. So we'll go back to Istanbul. Dr. Yildirim, is there anything else you want to add to your speech? Because I think that we are going out of time, and we need to go to the pediatric part. So as the last speech, if you have anything to share with us, I would be glad to hear.
About the emergency parts, we generally do not have that to emerge stuff, but the most important thing is to consume soft food, not to put yourself into those dangerous situations. That's the point. Just do what the doctor says. That's all.
Yeah, prevention is always better, the best way. Thank you very much again for your.
Thank you.
Thank you very much again for your invaluable speech and staying with us. I will go to Dr. Keshwat. So, Dr. Keshwat, is there anything you want to share with us?
No, thank you, Dr. Ab. It was an amazing experience to be here and share this outstanding speech. I hope to see you all soon.
So, thank you, everyone. Thanks a lot. So, we will have a short clip video. And after that, we will come back to Istanbul and we will give the microphone to our colleague, Dr. Didem Özdemir Özanen, if I'm telling correctly. And we will start the pediatric panel. So we will have a short break. So hello again, everybody. Now it's the time for pediatric dentistry. Hello again, Dr. Didem Özdemir. Hope you're doing well. Now I give you the microphone and good luck for the pediatric part.
Thank you, Dr. Arap. It's very nice to be in this collaboration event, and I would like to welcome all the audience again. And I would like to thank to the orthodontics part, orthodontics doctors. In pediatric dentistry today, we will have two speakers, and these are two valuable members of our community, pediatric dentistry community. First of all, I would like to introduce these two wonderful doctors. One of them is from Istanbul and the other one is from Iran, Tehran. First of all, Dr. Elif Sungurtekin Ekçi will be having the speak. She has graduated from Ankara University, and then she has got her PhD degree from Gazi University. These two universities are in Ankara, which is the capital of Turkey. And then she became an academic doctor in Yeditepe University after finishing her PhD. And then in 2012, she has become associate professor in pediatric dentistry. Today, Dr. Sungurtekin Ekçi will be joining us with the topic, Contemporary Approaches to Dental Emergencies in Pediatric Patients. And then we will have the second speaker, who is Ahmet Jafari. He's a great doctor from Iran, and he has been a dean in Alborz University in Karaj, and he has been the head of Committee of Dental Curriculum for the Ministry of Health and Medical Education in Tehran, is his country. Right now, he is an associate professor in departments of pediatric dentistry and community oral health in Tehran University of Medical Sciences. The title of his speak will be Clinical Dental Emergencies in Pediatric Dentistry. So I would like to give the word to Associate Professor Dr. Elif Sungurtekin Ekçi right now.
Hello to everyone. I hope you can hear my voice. I think so. Lots of greetings from Istanbul. First of all, it's a great honor for me to be among this valuable organization. And I would like to thank you all for joining and listening to our speech and session. So today I would like to present you my topic. First, I have to share my screen. Okay. I hope I can do it. Is that okay? Can you see my screen?
Yes.
Okay. My topic will be contemporary approaches to dental emergencies in pediatric patients. During my speech, we have two questions to think about, which one of them is which of the following is not among the indications of prescribing antibiotics in dental emergencies of the pediatric patient population? And the other is which of the following is not among the initial approaches to pediatric dental trauma patients? During my presentation, we'll find answers to these questions. So, what is emergency in pediatric dental patients? First one is severe dental and facial pain that cannot be controlled with analgesics. Acute infections of intraoral hard and soft tissues. Uncontrolled dental hemorrhage, dental trauma, facial swelling, and of course, the most common reason for admission is pain due to dental caries. Here are some examples to emergency admissions in pediatric dental clinics. Fascial swellings or trauma are the most common ones, and also intraoral and extraoral abscess are also is the topic of presentation. In a study in Brazilian Journal of Oral Research published in 2012, in a university, it subjects a university of pediatric dentistry clinic, and the reason for admissions to dental emergencies. So the most common reason for admission is dental pain, followed by exfoliation and eruption problems, dental trauma, soft tissue lesions, dental caries, and other reasons are the topic of admissions to dental emergency clinics. So what should be done with a patient after his or her admission to our emergency clinic? First, we have to take a detailed medical history, followed by a dental history and his chief complaint, of course, and a detailed clinical evaluation of the complaint area, such as pain location, severity, stimulating factors, analgesic usage, or the characteristics of pain, such as it is spontaneous or provoked pain. And then we have to make a detailed intraoral and extraoral examination. While examining the tooth with the chief complaint, we have to make palpation, percussion, and mobility tests in order to further diagnose the situation. And also radiographical examination is an important aspect of the examination. First, we have to take periapical radiographs or panoramic radiographs, or sometimes dental volumetric tomographies if needed. So our first goal is to eliminate pain and discomfort in these patients. We mostly prescribe some drugs to these patients in order to relieve their pain and discomfort, and also their inflammation. So we mostly prescribe analgesics and antibiotics for this purpose. So when talking about analgesics, we have to consider about a few topics which I'm gonna tell you about. First of all is systemic factors such as bleeding disorders, liver and kidney problems should be evaluated first. And the analgesics should be taken regularly for the first 36 to 48 hours. And also in some resistant cases, in severe pain patients, we prefer multimodal therapy, which means you may alternate acetaminophen or ibuprofen regularly in 4 to 6 hour intervals. And also the drug dose should be adjusted according to the child's weight. The examples to analgesics we mostly use is paracetamol. It's a non-NSAID drug, which is analgesic and antipyretic, and it causes no stomach or bleeding problems, unlike non-steroidal anti-inflammatory drugs. Here you can see how we prescribe the correct dosage in children below 12 years and over 12 years in adults. And non-steroidal anti-inflammatory drugs is another choice. In children, we might prescribe this kind of antibiotics also. So they have analgesic, antipyretic, and in addition to paracetamol group, it also has anti-inflammatory and antiplatelet effects. The most popular drugs on this group, medications on this group, are acetyl salicylic acid and ibuprofen. But it has to be kept in mind that non-steroidal anti-inflammatory drugs are not preferred in asthma patients because they have antagonistic effects with steroidal anti-inflammatory drugs which are used for the treatment of asthma. Ibuprofen is one of the medications we prescribe in this category, and here you may see in this slide is the dosage used in children. The other medication in this category is acetylsalicylic acid, and you see the recommended daily dose in this slide. But it should be kept in mind that it might cause Reyes syndrome in children. So its prescription is not recommended in emergency patients because it might cause Reyes syndrome in some viral infections. So we should be cautious about its prescription. And antibiotics are also important for the emergency patients. We prescribe antibiotics in oral wounds, in acute pulpitis, draining sinus tract, or localized intraoral swelling patients. We also prescribe when we face acute facial swelling of dental origin or dental trauma patients in some cases. In oral wounds, things to be considered are firstly, host status is important because there may be systemic diseases, comorbidities, or malnutritions. And the type of wound is also important. It should be an open wound when we need to prescribe antibiotics. There's a little difference in the prescription of antibiotics, which is when we face fascial lacerations or puncture wounds, mostly topical antibiotics are adequate for the treatment of these situations. Whereas in intraoral puncture injuries or lacerations, or when we see open fractures, systemic antibiotics should be prescribed in these situations. Also, tetanus vaccine should be questioned at patient if needed. It should be administered, of course. And a minimum of 5 to 7 days of antibiotic therapy is needed for the treatment of this condition. Acute pulpitis is characterized by inflammation and abscess in periodontal and buccal tissues, and mostly patients present with painful lymphadenopathy, and they have spontaneous pain, night pain characteristically. And in these patients, we mostly prefer root canal treatment or extraction according to the situation. So we have to I just mentioned in the previous slides, we have to just examine both clinically and radiographically the situation, and we'll decide whether we'll make a root canal treatment or extraction afterwards. Especially one important thing is antibiotic therapy is ineffective if the dental pulp is infected. I mean, if the dental infection is limited to the dental pulp, mostly systemic antibiotic therapy would be ineffective in these patients. Sometimes we see acute facial swelling of dental origin, and in these patients, the patient's age, cooperation, required anesthesia, for instance, local or general anesthesia. The severity of infection, such as fever, malaise, painful lymphadenopathy, trismus, emergency room referral might be needed in these patients. So, in these patients, our first choice is penicillin group of antibiotics. Sometimes in resistant infections or very diffuse infections, we might combine with these drugs with metronidazole, especially if the anaerobic bacteria is involved with the situation. And also cephalosporins are also an option in these cases. In dental trauma, there are some cases where we prescribe antibiotics. We don't prescribe antibiotics in every case. Just we prescribe antibiotics in avulsion injuries of the permanent teeth. And in these situations, tetracycline or doxycycline is contraindicated for children under 12 years of age because we know its effect on permanent tooth discoloration. On the other hand, there is no evidence for recommending antibiotics in luxation injuries of primary teeth. Antibiotics can be given if there is accompanying soft tissue injury or systemic problem. So we have to examine the patient first in details. And if there's only a luxation injury or just a simple fracture of a tooth, so we don't need to prescribe any antibiotics. But if there is accompanying a laceration or puncture wound or any systemic problem, we might prescribe antibiotics in those cases. We mostly prefer amoxicillin, potassium clavulanate. And sometimes if the patients are allergic to penicillin, we might prefer azithromycin and clindamycin in these patients. As I said before, metronidazole might be combined with penicillin in anaerobic infections. The most common cases we face in the emergency clinics are dental trauma. Today, I will tell you in details about the trauma in primary teeth. So we have to take a history and physical examination, clinical examination, radiographic examination, and recording is also important. We have to think about the injuries classification and treatment method clearly before any intervention to the trauma patient. During history and physical examination, we should check the ABC, which are the most important aspects of any emergency case. These are airway, breathing, and circulation. And we should question when, how, where, or any unconsciousness happened during the injury. Or any previous medical interventions must be sought. And we should take medical history. And any lost restoration, avulsion, or tooth fractures, and any risk of aspiration should be considered. And in sometimes, in doubtful cases, we might request radiographs of the neck, chest, and abdomen, especially we are suspicious about the risk of aspiration. We have to take preoperative radiographs for the baseline and clean the extraoral area to see things clearly, and evaluation of extraoral and intraoral soft and hard tissues, teeth regarding fractures, displacement, or any mobility. Tetanus prophylaxis is important. If necessary, we should just refer the patient for tetanus vaccination. And afterwards, we should stop bleeding and clean intraoral soft tissues with antiseptics such as betadine or chlorhexidine. Also, during clinical examination or intraoral examination, we should think about if we see occlusion or step-shaped defects of the alveolar mucosa, this condition might suggest that there is a maxillary or mandibular bone fracture. Or if we see sublingual ecchymosis, sometimes we can think about mandibular bone fractures. So also any form of malocclusion, we can be suspicious about the fracture of mandible. Or if there is inability to open and close the mouth adequately, there might be the temporomandibular joint injury. So we should take especially panoramic radiographs in these situations to see both the jaws and the temporomandibular joint together. What should we do to the affected teeth by trauma? We should make mobility tests, percussion sound, sensitivity to percussion, response to pulp test, which is mostly not correct at the time of injury. So we should follow up closely. And tooth discoloration is also important. During radiographic examination, we should take periapical radiograph at 90 degrees, perpendicular to the long axis of the suspected tooth. We may take occlusal radiography, especially if we are suspicious about the foreign bodies embedded in soft tissue, or panoramic radiography, especially in situations that I mentioned before, such as problems in maxilla or mandibular bones, dentition, alveolar bones, and temporomandibular joints. The most simple form of crown fractures in primary teeth is enamel fracture, which is a kind of fracture that is confined with enamel. So in these cases, we don't need any radiographs. And sometimes if there is any discomfort regarding the sharp edges, we might smooth them. In all trauma cases, education is important. So we have to educate the patient or parent. It depends on the age of the patient about care when eating soft meals, just for avoiding further trauma to the teeth, and cleaning the area with an alcohol-free 0.1 to 0.2% chlorhexidine mouth rinse applied topically twice a day for a week. And in these cases, mostly no follow-up is needed. Here we can see an enamel fracture on this tooth, 51, and we see the fracture is confined to enamel. And also there is an accompanying luxation injury, which we will talk about in further slides. Enamel dentin fracture, the uncomplicated one, if we face a situation like this, radiographs are optional. We might take one if we are suspicious about the fractured fragment is embedded in lips, cheeks, or tongue. So if there is no situation like this, we need to cover all exposed dentin to avoid hypersensitivity. Parent education is important, soft eating is important, and we need to make clinical examinations about 6 to 8 weeks. This is enamel dentin fracture, which is uncomplicated, and we cover the dentin mostly with glass ionomer cements. In complicated crown fractures, fracture mostly involves enamel and dentin, and unlike the uncomplicated one, the pulp is exposed in complicated fractures. So we need to take a periapical or occlusal radiograph to see the involvement of the pulp, and in these cases, we might make partial pulpotomy, cervical pulpotomy, or root canal treatment. And we should cover the pulp with non-setting calcium hydroxide or non-staining calcium silicate-based cement. Education is also important, and we should make clinical examination after 1 week, 8 weeks, and 1 year, and radiographic examination after 1 year. Here is a complicated crown fracture in a permanent tooth. Sometimes we can use the broken piece, the fractured piece, if it is in a proper situation, and we might just repair the tooth with the broken fractured piece. In crown root fractures, fracture mostly involves enamel, dentin, and root. The pulp may or may not be exposed. Sometimes it can be complicated or uncomplicated. So in these cases, we need to take periapical or occlusal radiograph. And the first intervention we have to make is to make local anesthesia and remove the loose fragment. Afterwards, we see the rest of the remaining tissue, and if we think that it's restorable and no pulp is exposed, we may just cover the exposed dentin with glass ionomer cement, or if it's restorable but the pulp is exposed, we can perform a pulpotomy. And the third option is if the tooth is unrestorable, we might extract it. In any way, we should make clinical examination and radiographic examination extended to a year. Here we can see a complicated fracture, crown root fracture in a primary tooth. Because it's unrestorable, an extraction is preferred to treat the case. In root fractures, the coronal fragment might be mobile and may be displaced. Occlusal interference may be present. So we need to take a radiograph, and the coronal fragment is not displaced. Or if it is displaced but not excessively mobile, we need to make no treatment. We may leave it as it is. But if the coronal fragment is displaced and excessively mobile and interfering with occlusion, we have two options, which are we can extract only the loose coronal fragment, and apical fragment can be left in place to be resorbed. Or reposition the loose coronal fragment, and if the fragment is unstable, we can make a flexible splint for 4 weeks. And afterwards, we might make a clinical examination, follow-up examination extended to a year, and also radiographic examination for a year is also needed for these patients. In alveolar fractures, there is a mobility and dislocation of the segment with several teeth moving together. It's the most discriminating finding in alveolar fractures. In those cases, we can see that many teeth, primary teeth, are moving together. When we see this situation, we should think about the alveolar fracture. So in those cases, mostly occlusal interference is present. So we need to take a radiograph. And sometimes if the segment is displaced in a labial direction, a lateral radiograph might also be needed. The thing needs to be made is we should reposition the displaced segment, of course, under local anesthesia, and we need to make a flexible splint for 4 weeks. Also, patient and parent education are needed, and clinical and radiographical follow-ups extended to a year are also required. Following fractures, sometimes we see also luxation injuries. This might accompany the fractures, or we can see them solely in a patient. Concussion, in concussion cases, the tooth is mostly tender to touch, but it has not been displaced. So it has normal mobility and no circular bleeding. So no dislocation, but it might be positive to percussion, and no mobility is seen. So no radiography is needed in these patients. So there is no treatment needed, but of course, patient or parent education is important. Clinical examination to 8 weeks for follow-up is important. Radiographic follow-up is only needed if we are suspicious of any pathosis. In subluxation cases, the tooth is tender to touch and there is mobility, which is differing from concussion in this aspect, but no displacement occurs in subluxation cases as well. Sometimes bleeding from the gingival crevice might be noted, so no dislocation, but positive to percussion and mobility tests. So we need to take a periapical radiograph. No treatment is mostly needed in these cases, but soft food, eating soft food, not chewing with anterior teeth, and regular cleaning with oral hygiene. Regular oral hygiene habits are important, and we should also clean the area with chlorhexidine mouthwash. Are also for a week are also recommended to the patients. We need to make clinical examination to the 8th week, extending to the 8th week for follow-up. Radiographic follow-up is only needed when we are suspicious about any pathological situation. So in subluxation cases, there is, we say, mobility and of course bleeding from sublingual gingival crevice, and also we must note that no dislocation occurs in subluxation cases. In permanent teeth, if we face subluxation injuries, unlike primary teeth, flexible splinting for 2 weeks is required. In extrusive luxation, there is partial displacement of the tooth out of its socket in incisal or axial direction. So we need to take a radiograph first, and if the tooth is not interfering with the occlusion, we might let the tooth spontaneously reposition, or if the tooth is excessively mobile or extruded over 3 millimeters, then we should extract under local anesthesia, especially if we are suspicious about aspiration. Patient or parent education is important, and clinical examination extending to 1 year should be carried out, and radiographical follow-up is only required when we are suspicious about any pathological condition. In this case, the extrusion is over 3 millimeters, and the tooth was interfering with occlusion, so the extraction of the primary tooth was planned. In lateral luxation, sometimes the tooth is displaced, usually in palatal, lingual, or labial direction with a facial cortical bone fracture or contusion. So we have to take a radiograph, and we should check the occlusal interference first. If we can't see any interference, or if it is minimal, so we may let the tooth spontaneously reposition, so we don't need to do anything. We should wait for at least 6 months to let the tooth spontaneously reposition itself. But sometimes, if it's severely displaced, we should make local anesthesia and make extraction, or we might reposition with a special care to avoid any trauma to the underlying permanent tooth germ, plus splinting for 4 weeks. Patient-parent education is important, and clinical examination extending to 1 year is important. Radiographic follow-up only requires if we are suspicious about any problem. Here we can see lateral luxation. The teeth are displaced in palatal direction, 51 and 52. Since it's not interfering with occlusion, the teeth are left in place, and the patient was followed up. In intrusive luxation, the tooth is usually displaced through the labial bone plate, or it can impinge on the permanent tooth bud. Of course, we have to take a radiograph first, and then we should examine the radiograph regarding the position of the apex. When the apex is displaced toward the labial bone, the apical tip can be seen, and the image of the tooth will appear shorter than the contralateral tooth. But sometimes when the apex is displaced toward the permanent tooth germ, the apical tip cannot be seen, and the image of the tooth will appear elongated. In the previous guideline of IADT, extraction of the tooth is suggested in this situation. But now, in the most current one, the 2020, which the guideline which is published at 2020, it is just advised that we should let the tooth spontaneously reposition in itself regardless of its position. So we should follow the patient for 6 months to a year to see if any pathosis is occurring. During this time, for the very first 2 weeks, soft eating is important, and also cleaning the affected area is also important. So we should educate the patients or parents accordingly. So we need to make clinical examination extending to a year, and we can radiographically follow up the case if just if needed. This is an intrusive luxation. The tooth is intruded over 3 millimeters to the succeeding permanent tooth. In avulsion, the tooth is completely out of its socket. So the location of the missing tooth should be questioned, especially when the accident was not witnessed by an adult or there was a loss of consciousness. Because of course there's a risk of aspiration of the missing tooth. So if it is not found, we should question about the missing tooth. It's very important in these cases. And also there's a risk of being embedded in soft tissues of the lip, cheek, or tongue, pushed into the nose, ingested or aspirated. These are possibilities. Especially when there are respiratory symptoms, we should refer the patient to ER, to a medical exam. We should take periapical or occlusal radiograph to ensure that the missing tooth has not been intruded, because sometimes it might be confusing. The parents may come and say that the tooth was knocked out of its socket, but sometimes we might miss the situation. So we have to ensure that the tooth is not totally intruded. It is avulsed. So if we confirm the avulsion of the tooth, the avulsed primary teeth should not be reimplanted. This is the most important thing to consider, because unlike permanent teeth, avulsed primary teeth should not be replanted due to infections, patient cooperation, and hard to make splinting at those ages. Patient and parent education is important, and clinical examination after 6 to 8 weeks is also required, but no radiographical follow-up is required if the tooth is totally extruded. And also, we also should follow the patient when the patient comes to the 6 years of age regarding the situation or status of the permanent tooth, because sometimes permanent tooth or teeth might be affected by the trauma. So we should just check the current situation of the tooth when the patient comes to 6 years of age. Here's an avulsion case. So I would like to thank you for listening and for all your attention.
Yes, thank you, Dr. Elif Sungur Tekinekci. It was a very wonderful and nice presentation. And now I would like to invite Dr. Ahmet Jafari from Tehran. Please, Dr. Jafari.
Hello, dear colleague and dear professor, students. Let me share the slides. Thank you. I am Dr. Ahmed Jafari, specialist in the dentistry. From the Tehran University of Medical Sciences. Okay. I'm happy to participate in the joint program between Tehran University of Medical Sciences and Yeditepe University. As I heard the last week, our colleagues in the Yeditepe celebrated their graduation with the 25th anniversary, and I tell all my colleagues in Yeditepe University, congratulations. My topic is clinical dental emergencies in pediatric dentistry, focus on ingestion and aspiration. Dr. Elif said very in detail about the dental emergencies based on the patient, based on the patient and problem, dental problem. I want to have discussion about the problem and emergencies based on our procedures, not based on the patient. I have two questions about my session. The first is which one has the least effect on object aspiration during dental treatment for children? This question is to get aware the factors that ingestion and aspiration maybe have. And the next question is about the comparing between aspiration and ingestion. The purpose of this question is to get familiar with the chance of each problem of ingestion and aspiration during the dental procedure for children. There are some accidents during or after dental treatment. Some of them are non-emergency accidents. For example, chip or fracture of tooth, foreign body cut in the between teeth, for example, wooden bed, chip biting after dental treatment or scratching the skin after anesthesia, or some allergic reaction to dental materials. But some of them is emergency accident, for example, faint or laceration or excessive bleeding, and foreign body ingestion or foreign body aspiration. We focus in this session about the foreign body aspiration and ingestion. And the rate of this problem is very, very low. For example, around for complication about these two problems among the 100,000 patients. But the problem is very vital, and we must have attention and more attention to these problems. Why does ingestion or aspiration happen? As you know, we have a lot of small dental material or slippery dental material in our procedure. When we are providing dental services, the small object like a crown, band, and other things can move from the mouth into the throat for various reasons. And we work in a part of body that can have many danger. Vital organ, loose tissue, weakened thin mucosa, and high vascular gate of swelling and breathing. And worst of that all is that we are dealing with a child that in most of cases they are uncontrolled, or child unexpected movement make difficult treatment for us. Another item like uncovered mouth or improper equipment or bad chair position are very important to our procedure and our problem.
Yes, that's better. We have a technical issue, I think. Thank you,
Yes,
Dr.
yes.
Jafari. Yes, this
sorry.
is better.
I'm
No,
sorry.
it's okay. Thank you. We
Yes.
can see better right now.
As equipment is important, the person is important too. For example, in Iran, we have a course for dental assistant who works in the office of specialist, or for the general dentist who works more for child. Other thing is for example, nausea, gagging, and aspiration of vomit is the cause of aspiration and solid. The first place is oropharynx, that the material fall in the oropharynx. After that, about 93% of materials goes into the gastrointestinal tract, and nearly 7% goes into the tracheobronchial tree. As you know, foreign body aspiration in adult is rare, and based on the anatomy of airway in the children and adult. Okay, this slide shows that the organs, vital organ in the head and neck. After following the material into the hypopharynx and oryngopharynx, they can go to the esophagus or into the trachea. There are some differences between the child and adult, as you can see in this slide. The pharynx in the child is higher, and the vocal cord and the trachea is the shape of funnel shape, that it helps to go to the trachea. But maybe it is the good chance for us to lock in the place in the cricoid area. Some foreign objects that we see in this slide, like teeth, instruments, clamp of rubber dam, gas packs, cotton roll. Some of them are slippery. Some of them are very small and maybe fall in the falling. Impression material crown, especially stainless steel crown, endodontic instrument, and orthodontic material of other things like bracket and band. The cause of falling object is especially like this unexpected movement. As I say, we are dealing with a child, and most of them fear to dental procedures. Gagging is a common among the children. Uncovered mouth is the main cause. It means that we must have used rubber dam to cover the mouth and protect the foreign instrument. Dental fillers and big hand of operator and small mouth of the child. And then next thing is a small okay. Now we talk about the ingestion of objects. We want to know what effect of the foreign bodies in the pharyngeal area, what effect scratches and laceration of pharyngeal mucosa and perforation, especially with the sharp and cotton material. After that, if there is a perforation, a retropharyngeal abscess may be seen, and soft tissue infection and abscess is another thing. Also, some problems occur when objects enter the gastrointestinal tract. Although the most of these problems have not seen in the dental procedure and complication about the dental procedure, but we must know about them. For example, the scratches, laceration, and abrasion of mucosa. This happen after going to the stomach and intestinal tract. Esophageal necrosis, based on the perforation and remain for a long time. Esophageal restriction that it makes difficulty to eating, and esophageal perforation and subsequent paranasophageal abscess, mediastinitis, pneumothorax and pneumomediastinium, pericarditis, and cardiac tamponade that the fluid in the tamponade space, tracheonasophageal fistula, and acute and subacute small intestinal obstruction. Symptom of foreign body in the stomach or intestine shows itself like pain or cramping the abdomen, abdominal swelling or bloating, loss of appetite, nausea, vomiting, fever, and blood in stool. And both of diarrhea or constipation will be seen. What will be our diagnostic process? It is necessary to careful examination of the entire oral cavity, pharynx, larynx, and esophagus, but the necessary equipment is not available in the dentist office. As we know, we have not enough equipment and instrument for save the patient. On the other hand, the dentist does not have the necessary skills to do this, because the dentist rarely encountered these problems. But these problems are very vital. We need to get help from our doctor colleagues, general practitioner, and need to general physician, and need to call the medical emergency center. Some other investigation, such as chest X-ray, abdominal X-ray, and endoscopy will be done in the hospital. In most of the cases, it does not need anything in the ingestion, but in 10 to 20% of the cases require non-surgical intervention, and around 1% or less require surgical intervention, especially when the foreign body is large, sharp, or cutting that are lodged in the esophagus and should be removed by endoscope. And it needs X-ray if the object is radio opaque. In negative imaging with no evidence of damage can often be managed conservatively with follow-up at 24 or so to check the that they remain well. Passage of object in the stool may take days to weeks, for example, for 2 weeks. And parents should observe for this antidepressants. And the diet in a high fiber and frequent ingestion of soft food items such as banana or moistened bread, maybe aid to the passage the solid foreign object. To treat the solid object during the dental procedure, it must be categorized according to the symptom, asymptomatic ingestion and symptomatic ingestion. If there is no symptom and it is asymptomatic foreign body ingestion, it categorized it by the object type. If it is radiolucent and elastomic material, only reassure the patient that there is no problem. If there is a problem, tell us, and we must guide the patient parent depending on the problem. But in metallic materials, if the solid object is sharp, it may need to be referred to a hospital. Parents should check their child's stool to make sure it is accepted. If it is symptomatic for body ingestion, it categorized by the time of showing the signs and symptoms. If it is immediate, like discomfort and vomiting, etc., we must use the radiograph to ascertain the foreign body location, and sometimes it is needed to emergency expert medical intervention if it is a sharp or cutting material or large. And some symptoms is shown in the some days or some hours later, that must lead the patient to the hospital, and it shows that complication arising from the perforation along the GIT, gastrointestinal tract. To treat a solid object during the aspirated material, we must more attention. This is the sign, universal sign for choking, and it means vital help to the patient. We must know why the foreign body aspiration symptom or foreign body aspiration, cause of it, risk factor, and diagnosing the place of material, at physical examination, treatment, and emergency medical treatment of child. The cause of the aspiration is the same ingestion, but in the pharynx, breathing at the same time lead to the lead body to the trachea, and especially in immature protective laryngeal reflex, it help to go to the tracheobronchial tube. Some symptoms of foreign body aspiration, like cyanosis, choking, coughing, difficulty breathing, dyspnea or tachypnea is seen, and some abnormal breathing sound, rolls, rhonchi, stridor, and wheezing. If sound is abnormal or difficulty in breathing, we must more attention to the complication. This complication, like pneumonia, subcutaneous emphysema, pneumothorax, and pneumodysthenia, granulation tissue and hemorrhage, and cartilage destruction, airway compromise, and unfortunately, this may be. At first, it needs physical examination by endoscope instrument and X-ray examination, and pay attention to the symptom of aspiration. To treat a solid object during the dental procedure, it must be categorized according to the symptoms. Look for these items: inability to talk, for example, difficulty breathing or noisy breathing, any abnormal sound, coughing, which may either be weak or forceful, skin, lips, and nail turning blue, that shows cyanosis, skin that is flashed and then turn pale, and loss of consciousness. In the asymptomatic, that means no area obstruction, we must reassure the patient and refer for a specialist medical care, and take chest X-ray and followed by specialty center like hospital. In symptomatic, because choking cuts off oxygen to the brain, give first aid as quickly as possible. If the person is choking and cannot talk, cry, or laugh, American Red Cross recommended 5 and 5 approach. It means 5 times for back blows and 5 times for abdominal thrust. If there is acute respiratory distress with cyanosis, it means complete airway obstruction, and at the first time we must administer first aid, attempt dislodge with the repeated back blows, and at the same time emergency, it needs emergency expert medical intervention. That means call immediately to the emergency center. If there are some symptoms, but the airway is partial obstruction, the same steps with the completely obstruction, but it is better situation that we have time to do the first aid for our patient. We try to the back blows, and if the foreign body thrown out the respiratory fluid, it's good and it is not emergent, we can refer the patient to the hospital for another examination, full examination, and take chest X-ray. And if it's not true, we must continue all steps until medical help arrive. In this slide, we see the position for infant and young child. Okay, it is important that what must we do to prevent the ingestion and aspiration. The child would be mentally ready for dental treatment. Control the child gag reflex. Use rather than tie the clamp and other things like, for example, file with treat dental floss. Keep calm and postpone the treatment session if you guess the maybe problem will happen. How can we prevent the foreign body ingestion? Another item that we must attention is based on our dental assistant. It is better to train our assistant to help us during the dental procedure. As I said, in Iran, we have a special course for dental assistant in the pediatric dental office or general practitioner that works more for children. We must careful of sudden movement of the child head and bend the child head slightly toward the side that we are working on, and avoid the very supine position. But sometimes we work for a child in the very young child, for example, less than 2 years, in the position of lap to lap with mother. We must be very careful and we be careful. During extraction, must careful of the dislodgement and release the tooth from the forceps. Use gas when you want to try a synthesis crown on the tooth or remove it. And it needs more careful when using a small object. Have a high vacuum function suction and control the child fear and gag, and be careful the possibility of vomiting aspiration. This is very important. Use of high volume vacuum in order to reduce vomiting chance in uncooperative children. It is recommended to perform dental procedure with empty stomach, no eating a lot, and have a suitable chair position for all patients. Thank you so much, and I'm sorry for the problem among my session.
Thank you, Dr. Jafari. It was very nice presentation. You had a little bit technical issues in the beginning, so it was a little bit intense, but we could all see the slides. It was all clear. And so I would like to give the word to the audience. And are there any questions or curious about these two wonderful presentations? You may just write from the chat, or you may just, you know, put the hand signal from the chat part. Whatever you wish, whatever you like, we can ask to these both wonderful speakers about the pediatric dentistry sessions.
Dear Dr. Özdemir, I'm very sorry to interrupt you and interrupt the pediatric section. We have a surprise now. Dr.
Okay.
Milani, one of our best colleagues from pediatric department, has also joined us. So she will also stay with us in the discussion part. Hello, Dr. Milani, welcome. I just don't want to talk a lot because we are going to run out of time. So I will give the microphone again to Dr. Özdemir and to our dear audiences for asking their questions. Thank you.
You here with us
or not? Everything's all right? Dear Dr. Arab, Dr. Özdemir, I do not have your sound.
Dr. Milani, I have your voice.
Yeah, okay. I think now it's going to be fine. First of all, let me uncover myself. This is me, Shabnam Milani from the Pediatric Dentistry department. It was a great pleasure to be with you, even virtually. It is a, I think, very advantageous program that has been scheduled between Tehran University and Yeditepe. First of all, I would like to say we had some technical problems with the system that we were just having a presentation. So I'm just here with you from now on because I had just finished my work. I had some time to be with you and enjoy some time with my Turkish friends in Yeditepe. I'm here, Dr. Arab, Dr. Oznan, and Elif. I can't see the last name, sorry. Okay, I'm here.
So we were talking about the pediatric dentistry emergencies, and Dr. Efsungur Tekinekci talked about the emergent cases of actually concerning about oral issues, and Dr. Jafari talked about the dental emergencies of in general for the pediatric patients, like swallowing some objects, etc. So do you want something to add, or do you want something to comment, or questions? We would like to hear them, or if you want to, talk in general, we would be happy to hear. Thank you.
Well, it was a great surprise for me to be here. It was a little bit unexpected, but I'm trying to just add some kind of emphasis on the things that have been talked about already. Traumatic cases, as I think it was one of the topics of the presentation today. It is obvious that is an emergency, and I think maybe you can find the treatment plans, how you should manage it in the books. We have different books about traumatic cases. So I will be here with you for the questions for the traumatic cases, but I want to just emphasize more and some emergency cases that may happen because of ingestion and aspiration, and that's mostly because of the size of the oral cavity of a patient, pediatric patient, and especially when we're working with children because of some kind of uncooperativeness of the children. When you are working with stainless steel crowns, the child suddenly moves, starts crying, nagging, and it is not something that is really to handle, So our students, we always recommend, for example, when they're trying a stainless steel crown or even a space maintainer, just to have a complete control on the area. So it's not just removing the crown with an excavator or carver or things like that, and you get happy because that I have just removed the crown, but because suddenly in a blink of an eye, you can see that the crown slips posteriorly to the throat, and that's when you just feel nervous and you cannot manage it. So it is preferred that from the beginning of your work, you have complete control on what you're doing, and you have the tongue of the child, the buccal pad, also the instruments that you're using, they should be all supported. You can use a rubber dam, that's the ideal thing that we can use for preventing such emergency cases. If not, you can use a gauze. You can put in the posterior in the oral cavity, because it may seem something clear, but some of us sometimes forget about it, and the consequences are really bad. So again, I'm just emphasizing on the emergency cases that can be prevented easily. I'm sorry for talking too much. So I'm here with you for questions.
Thank you, Dr. Milani. It's great to have you here. And so it's great to meet you. And so are there any questions for both speakers? For Dr. Elif Sungur Tekinekçi, first of all. And she talked about a lot of traumatic issues in the permanent as well as primary teeth. And she actually mentioned about the avulsion of the primary teeth. Sometimes the parents get anxious and they say, so you won't put back the teeth? And sometimes some dentists, general dentists as well as pediatric dentists, sometimes get this confusion. And if we are confused about what to do in these cases, what do you suggest for us, Dr. Ekci?
Dr. Özanan, thank you for the question. In general, when we face such emergency cases in primary dentition, especially with avulsion, yes, there might be some confusion among the dentists and the parents because they don't want to lose the teeth. They want them back. They have aesthetic concerns mostly. And also some maybe feeding problems accompanying. So with these concerns, they try to replant the tooth. The family can do this, or sometimes the dentist making the first intervention might prefer this. But anyway, in any condition, the replantation of primary teeth is not preferred in pediatric patients because of the age, because of the cooperation of the patient. Risk of aspiration is very critical in these patients. Risk of infection is also important, and during replantation there's always a risk for further trauma to the succedaneous teeth, permanent teeth, and also splinting is another issue in primary dentition. It requires patient cooperation. And it is it requires some dry conditions you to work with. So it's mostly hard in this patient group in primary dentition. So to avoid all the risks, it's mostly preferred to avoid the replantation of the primary teeth.
Thank you so much, Dr. Ekci. It's very nice answer. So I would like to ask another question to Dr. Jafari, if it's okay. So he talked about the aspiration of some objects, and also it can be swallowed. Sometimes the parent cannot be sure if the child has swallowed or aspired some object. And what can we do to understand exactly if we don't have the medical support right away, and to differ these? Thank you.
I will be here with you for some time, if it's okay with you. You know, we do not usually have a lot of problems with swallowing emergency cases, because most of the times, maybe about 90% or things like that, we do not, it will be just defecated after some time. But from that session on, we always instruct parents to check the stool every time, and usually they find it. But if not, they will be referred to the physician for further radiographics. For example, maybe some kind of from the stomach area, maybe they need some kind of radiography. But for case of swallowing, most of the times it's stainless steel crowns, and since it is not a sharp object, so we do not have any worries, and after some time it will be defecated. But if the parents could not guarantee that they have found it or not, so we will refer to the physician to check for some radiographs or things like that.
Yes, thank you so much.
If
Dr.
you
Milani.
have any other options that you do in your own practice, I will be glad to hear that.
We do the same actually. And first of all, I check if the child is breathing normally. If it's an issue of aspiration, the breath must be shortened a little bit, right? So I check the breath. It's very important to check it. First of all, that would be my first advice. And then mostly, as you said, it would be swallowed and defecated after. So I will ask the parents to check. You know, it's not good to check, but with the gloves, actually, I give them a couple of gloves and I want them to check, you know, for sure. Because if it's like swallowed, it will be shortly defecated after like mostly after 1 or 2 days.
Yeah, as you said, there is a discrimination between swallowing and aspiration. First, you asked about swallowing. When the child swallows an object, it means that it has gone to gastrointestinal tract. So we are hoping that it will be defecated. But if it goes the other way, it goes for aspiration. So we will have some changes in the breathing routine of the child. So it will just show it itself right away. So, you know, so the discrimination is sometimes, I think it is clear.
Right. So it's clear mostly. So are there any further questions from the audience? Since we all, the speakers and I, for myself and Dr. Milani as well, we are all the pediatric dentists. We have all the questions, we have all the answers, but the audience maybe have further questions because, you know, sometimes if a child approaches, mostly the general dentists as well as the other department dentists, they will usually like pause a little bit and then they will just think, oh, that's a child, you know what I mean? And then they will like a little bit approach anxiously and they will be tense. But if there is a case of emergency, you know, dental emergency, we all dentists have to do something at one point. So here the two valuable speakers have talked about, and as well as Dr. Milani talked about a little bit the approaches of these dental emergencies. So are there any further comments or questions? Please feel free to ask or write on the chat part. We will all appreciate. I think there is not. So I would like to give the word to Dr. Arap, our moderator, and I would like to thank you all, the speakers, the audience, for your attendance. And also I would like to, you know, thank to Dr. Pogan Amini Shakib from Iran Tehran University for moderation and organization. And I would like to thank to our team, Dr. Karapınar, and Dr. Özçakır for this good organization and event. Thank you so much. Thank you all for your attendance.
Thank you very much. Again, I would like to take this time and express my deepest gratitude to Dr. Amini Shaki for organizing this program. And also I would like to thank the international part of Editepe University, all the speakers today, Dr. Kishwat, Dr. Yildirim, Dr. Özdemir, Dr. Elif, and Dr. Jafari, and special thanks to Dr. Milani who joined us. I hope to see you all guys in our next meetings, and I hope that this panel was informative enough for the audiences. So our colleagues from Department of Endodontics are gradually joining us, so I think that it's the time to give the seat to Department of Endodontics. Once again, I would like to thank you all, and I look forward to seeing you all in our future meetings. Thank you, everyone.
Thank you, everyone. See you in Iran.
Thank you. Goodbye.